All right, welcome to session Oncology 1, prostate cancer. My name is Hossein Jadwar. I'm from the University of Southern California in Los Angeles. And my co-moderator or co-chair for this session is Dr. Michael Hoffman from the Center for Cancer Imaging at the Peter MacCallum here in Melbourne. Before we get started, I just want to remind you a few things, and which I'm supposed to read for you. That's if you could please put your phones to a silent mode so that the speakers and the rest of the delegates in the room are not disturbed during the presentations, please. Also, please download the conference app. There's a lot of information there, and you can refresh it so that you have the most up-to-date information on every session that occurs at this particular Congress. For those who are interested in CME, please go after each session, go and capture the QR code which is displayed on the screen on your app so that you can receive the CME for that particular session. So in this session, we have 3 talks, each are 30 minutes, and we were told that we have to be on time. Hopefully the speakers will stay within that 30 minutes, and if they stop a little bit earlier, we may have some time for questions. At this point, I want to give the podium to Dr. Hoffman to present the first speaker.
It's my pleasure to introduce Associate Professor Declan Murphy. Declan is a urologist and head of the Uro-Oncology Service in my institution at the Peter MacCallum Cancer Centre. And I would describe him as an early adopter of new technology, which fits in great with what we're trying to do. He was one of the early pioneers of robotic prostate surgery, and now he's really adopted PSMA very early on and used it to personalise his care and improve the outcomes for his patients. He's also has a big presence on social media. If he was at a urology conference, everyone would already be tweeting by now. So for those few in the audience that are into Twitter, take the opportunity to upload a few photos. Declan will appreciate that. So my pleasure to hand over to Declan.
Thank you very much, Michael. Thank you, Hussein, and thank you very much for the invitation to speak at this fantastic meeting. Of course, I'm probably one of the very few surgeons at this World Nuclear Medicine Federation, but it's very, very important for me that I attend these types of meetings. And I think it's also important for you, the Nuke Med community, to hear some clinical perspectives, especially in an area like prostate cancer that's opening up so rapidly for your community. I think if we sat at this meeting 10 years ago, there's no way we would be in the main plenary. I think 10 years ago, prostate cancer oncology at any kind of nuclear medicine meeting would have been in the back of the trade area, maybe a few people huddled around a circular table with some coffee, because that's all it had to offer, to be honest with you. But boy, how we've moved on. And I must say the past 5 years in particular for me, especially working with such great colleagues as Michael and Rod Hicks at Peter MacCallum Cancer Centre and others who I will acknowledge, has been a revelation to me. So in my talk, I'm not going to give you a lot of data because I think you guys already know a lot about the data, and you're going to hear it in other forums about PET imaging, particularly PSMA PET imaging, which is, of course, has been the trigger for our current interest. And instead, I'm going to focus on 3 very important clinical areas in prostate cancer where we need your help, frankly. And it's in those 3 areas that we have seen huge advances, and we're very grateful for that help. As I mentioned, I want to acknowledge Rod and Michael, and also acknowledge my other colleague, Zita Balak, who works with us here in Melbourne at Monash University, Monash Medical Centre. Also my other multidisciplinary colleagues as listed here. I have no disclosures. So these are the 3 areas I'm going to speak about, and it's specifically focusing on PSMA because that's the only real player in the clinical end from my perspective as a urologist. Of course, there's all the various types of PSMA we're now using. It's been the gallium-labeled ligand, of course, that triggered the huge surge in data on this, but more recently fluorinated PSMA and other isotopes you're hearing about are of interest. So let's think first of all about a disease area that's very common and that you've seen a lot of data in. And I'll start by giving you a very typical experience, unfortunately, from our practices working in early prostate cancer. Here's a patient who presents with a raised PSA, has a biopsy, has an MRI scan, as everybody tends to have, has a lesion, and undergoes a radical prostatectomy. And what you see on the slide is, in yellow, some extracapsular extension, which happens in about 30% of our patients. Just a little bit of disease coming through the capsule. And what does this mean? Well, he's had a great result initially. His PSA has become undetectable, but now, a year later, the PSA is beginning to rise. And this is the classic situation of local recurrence, or is it distant recurrence? We never know because imaging doesn't tell us anything or has not told us anything. So the patient undergoes salvage radiotherapy, the PSA goes down a little bit, but here we are 2 years out, he's had surgery, he's had radiation therapy, and now his PSA is rising. That equals very stressed patient. We often say PSA stands for patient stress and anxiety. And this is exactly what happens in this situation. For what it's worth, they have a CT and a bone scan, useless tests, always normal. What now? Is this rare? No, this is not rare. This happens to up to 1/3 of all the patients with early prostate cancer around the world who undergo either surgery or radiotherapy. 1/3, that's tens of thousands of patients every year with biochemical recurrence and no evidence of disease on imaging. And that's where you've all come in. Why are we interested in understanding where this PSA, where this recurrence is coming from? Well, it's driven by another topic that I'm going to speak about, which is oligometastatic disease. A terrible, terrible term that I hate, this oligometastatic disease. And it's only really come into prostate cancer in the past 3 or 4 years as imaging has improved. And we wonder, is there a disease state truly where patients have such low volume metastatic burden that perhaps we can offer them a meaningful cancer outcome? And we've written about this before, and the whole premise of this is, if you can truly identify all the disease and then truly ablate or resect that disease, could you possibly cure some of these oligometastatic patients, or at least defer their need for systemic therapy and improve survival? But of course, the big weak link here is the very term oligometastatic is a function of imaging sensitivity. And if you're counting 3 bone lesions on an old technetium bone scan as being oligometastatic, then you're going to be very disappointed when they don't respond to targeting of those 3 lesions when the sodium fluoride PET scan or the PSMA PET scan is showing the true extent of disease. And what about other imaging? Well, here's a very high quality MRI scan from my friend Jelle Barentz, who's a world famous leader in MR in Nijmegen. And he tells us that that little thing that is circled on this MR is a positive node. It's prostate cancer, 4 millimeters. And some of the very good MR people, even without nanoparticles and other areas of interest, will tell us this is good enough. We don't think that's good enough. In fact, Hoffman and Hicks, my very famous colleagues at Peter Mac, have written about this, and I love this term they've described in other disease areas, lumpology. Because in this biochemical recurrence setting, even an MR with its very good spatial resolution is only showing us lumps. And when we show the patient a lump and the PSA is up a little bit, is that just a normal anatomic lump, or is this cancer? And if it is cancer, is it a cancer that we need to be worried about, or is it an indolent little bit of low-grade prostate cancer, as we often see? And this is my segue into how PET imaging can help. And I'm just going to show you 2 or 3 short slides to show you some of the messages that the urology community are receiving in the very many publications that have been come out in this area in the past couple of years. This from Munich, from Tobias Maurer, Matthias Eiber and co. And they summarize this in Nature Urology, saying the value of PSMA PET is it adds molecular information to the lumpology, much better accuracy, sensitivity, and specificity compared to existing conventional imaging, or indeed other molecular imaging. And even at very low levels of PSA, like the example I showed you, we are detecting lesions, which will bring us into a conversation of, does that really matter actually? And this is a picture from Maurer's paper showing the typical oligometastatic state on a bone scan on the left, and then the true state with a PET scan on the right. And in our center, we see lots of examples of this. We have a paper in press of a prospective study of stereotactic radiation for oligometastatic disease in our center, where patients were selected on a bone scan, but then had a sodium fluoride PET scan before we did PSMA for everybody. Again, showing that you call out a huge number of patients straight away who are not truly oligometastatic. And I also like showing these papers because it's showing you that urologists, radiation oncologists, medical oncologists are teaming up with nuclear medicine physicians to get these messages out. And all of these nice review articles are typical of that. We've described PET as an evolving gold standard for imaging in prostate cancer. And we've separately written that despite our great enthusiasm in our center for this, we do truly need to better define the role. And that'll be an outstanding issue that we'll come back to later. So I'm not going to show you data, but I will show you some examples just to give you some idea of the impact, the huge impact these types of investigations you've brought forward are having in our practice. So here's a 67-year-old patient of mine who had a robotic prostatectomy 6 or 7 years ago. His PSA was about 50 at the time he came in, so he had very high-risk disease, high chance he's got micrometastatic disease. And now his PSA is rising. His PSA is 1.2, so that's quite high for someone who's had a prostatectomy. He's M0 by conventional imaging and also by choline-based imaging and whole-body MRI, because he was part of a prospective study investigating whole-body MRI and choline that Louise Emmett was leading. So here's his first PSMA PET scan, which is showing multiple retroperitoneal nodes, all of them less than 1 centimeter in size, so invisible by conventional criteria. And the largest node he has is in the left supraclavicular region. And this was something we never really appreciated, how often metastases will skip up here and land in the left supraclavicular region. And we used to biopsy many of these lesions 3 or 4 years ago when we started this imaging, and we biopsied this one and find it's a high-grade prostate cancer, a little dot sitting up there, so the rest will be the same. And we've stopped biopsying these lesions unless they're equivocal because it's almost always right. I think the specificity is extremely high with this type of imaging. So we get the answer, and that will dictate the systemic treatment. Here's another one, prostatectomy, very straightforward. The preoperative PSA is 9, so if this patient is cured, as one might expect, or high chance of cure, the PSA should be undetectable. But it's always disappointing when the patient comes back and you say, well, the PSA is almost the same level it was before your prostatectomy, sir. I'm sorry about that. And this happens a few times a year in our center because we're a very large center. Conventional imaging negative, but here's the true state with his widespread distant bone metastases, even a very large lesion down here in the pelvis, invisible by conventional criteria. So this helps resolve all of these situations where we know there is cancer. The only explanation for this patient post-prostatectomy with a PSA of 7 is he has cancer, and here we find it. Resolve it all. One quick scan, there we go. Here's another one, which is an interesting lesson for us. A patient had a prostatectomy a few years ago and had radiotherapy. So like the first case I showed you on the graph. Now his PSA is 0.9, so that's low. He's had a CT of his abdomen and pelvis and a bone scan, which are negative, because that's typically where we look for recurrence at these low levels. So he was referred in for a PET scan, and what do we see? We see a lesion in the chest that you can see on conventional CT, but we don't normally do we did not normally do a chest CT in these settings beforehand. And he's got this avid lesion in his chest, and yes, we've taken that out, and it's prostate cancer. Distant visceral disease. One scan, there we go, that's the answer. We have hundreds of these examples, which I won't torture you with. Also, in patients who are being considered for radiotherapy, and Louise has published a very nice paper on this that I didn't want to take away from, but I'll show you an example. Very similar again, extracapsular disease, the PSA is 0.1, and for us that's a typical trigger for postoperative or salvage radiotherapy. But about half of these patients overall will fail. Why do they fail? Probably because that's not where the cancer was in the first place. Do you do any sort of imaging? Well, what happened, he's in a separate prospective study that Zita Balak is involved with, and what he has is retroperitoneal nodes, well above where the radiation field would be, even at this very low level, as Louise showed in her BJUI paper recently. A small percentage of patients in this setting will have disease outside the pelvis. Therefore, why do radiation therapy into the pelvis? We shouldn't throw that baby out, but it certainly makes you think. And post-radiation, when the PSA is rising, I think this is one of the areas that PSMA is standout performer. So the PSA is rising, they've had radiation, the prostate's still in there. MRI has a role, biopsy has a role, but PET imaging has a great role. Here's a patient who's had seed brachytherapy in the past, and you see this very avid lesion here on the anterior aspect of the prostate where the seeds have missed. Classic picture we see, and then when we go on and do a radical prostatectomy for a patient like this, we'll often see, as you see in this image here, brachytherapy seeds outside the prostate. This is the prostate here, the apex is up here, and all the brachytherapy seeds are outside the prostate. So there's a cold spot where the PSMA is avid. It's very impressive. And this is the same pathology from that patient, again showing seed distribution away from the lesion, which is circled here. Very nice correlation with the PET imaging. We've done a systematic review on this in European Urology, which we're about to update, and I think this gets cited a lot because it was one of the earlier publications saying, what's going on, how good is this? And it is very good for biochemical recurrence at these very low levels that you see here. As the PSA rises, of course, the scans are more likely to become positive, but the area of interest is probably down here on the left where the PSAs are quite low. And is it meaningful to find disease in these patients? That's the outstanding question. That's again just showing as the PSAs rise. So my take-home messages on recurrence are, yes, PSMA PET, most impressive for detecting disease even at very low levels. Very high specificity, and the sensitivity is still related to the PSA level, which of course reflects disease burden, but most impressive. However, we do need better comparisons, better prospective comparisons. We need better tissue validation data, if possible, and particularly around decision impact. We need to understand, okay, this is a novel test, it's probably right most of the time, but the way in which that information affects our decisions is something we still haven't fully explored. The next thing I want to talk about is treatment. You're going to hear, you've already heard actually about the theranostics capabilities of PSMA and other ligands, actinium, for very advanced prostate cancer, but there are roles earlier on as well. And I'm going to divert for a minute to talk about something completely different, which some of you may or may not have heard speak about before, and that's Pokemon. So you all might remember almost 2 years ago when the whole world seemed to go crazy for this Pokemon Go, which was this app you download in your phone, and people are going around the place trying to find these little Pokemons walking around the place, and they're seeing them in bushes and in front of trains and stuff like that. There were all sorts of examples of how the world has gone crazy trying to find these Pokemon, and people are crashing their cars. And here you see Central Park at midnight in New York when word went out on social media that a very rare Vaporeon had appeared in Central Park. So people are literally abandoning their cars on Fifth Avenue to go and grab it on their phone. So the Pokemania is what it was called. It broke all sorts of records for billions of downloads, and as usual, these things come and go like any fad. And I'll come back to that in a second, but I want to show you what I think is oligomania, which is kind of what I've been hinting at, that only in the last few years we've become very interested in identifying these very low-burden disease states. And this is the number of publications on oligometastases in prostate cancer. We've published about this in European Urology recently, and you can see there's been a surge. And why is that? Well, we've also editorialized about the plague-like proportions of PSMA PET imaging happening in this country. This country has been infected by the PSMA virus thanks to all you guys, really. You seem to have made it available very widespread, very affordable in Australia for some reasons, and it's become almost a community scan outside research protocols. Back in 2014, when Michael and co were the only provider in Melbourne, these scans were costing typically about $900 and we were getting 12 requests a day for PSMA PET scans because the word had got out from the Heidelberg data and others. Fast forward a couple of years and there's about 14 or 17 or 18 providers in or around Melbourne and Victoria. The price has come down and you can pretty much get a scan the next day. And that means a lot of inappropriate scans are getting done as well. So there's a plague-like phenomenon going on here. And I'll come back to why that's important. And if you think about the Pokemon premise, it's about you got to catch them all. So that's what you got to do. You got to go around with your phone and grab that Pokemon there and grab these two over here, these two nasty beasties over here, and get that one over there tweeting from the chairman's podium. Zip, got him. Okay. So you got to get them all these things, and people go crazy trying to get their Pokemon. And that got us thinking about POCA-MET, which is this term we've come up with and published about. Do we really got to catch them all, is the question. All these irritating, avid lesions that you keep finding on scans, and patients are seeing them going, there it is. We'll say, well, maybe it doesn't matter. What, you're going to leave it there? So we got to catch them all. So that's what happens. We do some stereotactic radiation therapy and a bit more and a bit more, and then we'll do a salvage node dissection, and then, it pops up back down here because this is not actually sensible. This is systemic disease popping up and down all the time. But we definitely are seeing a POCA-MET phenomenon, and we've editorialized about that in European Urology, which is our big journal. Do we got to catch them all, is the question. So this is a lingering question that we have to think about in this era of PET imaging for biochemical recurrence. And I've shown you that you've got this oligomet mania, and I think it's the PSMA PET craze in certain countries in particular that's feeding the oligometastatic craze. So that disease was always there. Some patients are going to do quite badly. Many patients do perfectly fine, by the way, even with a little bit of lymph node disease and low-level PSAs for many years. If we never saw this stuff, it probably wouldn't matter. And we've published some examples about that. But apart from that whole philosophical question about, do we need to find these little buggers and do we need to chase them with radiation or surgery or whatever? There is some other value that I want to briefly draw your attention to, and this is this area of PSMA-guided radiosurgery that the Munich group in particular have had an interest in some very nice publications, including one just last week in European Urology. So I've already said to you that you've got these irritating avid lesions, and Michael knows this well from our tumor board meetings. Sometimes they'll show us these presacral internal iliac lesions, and we'll do an extended node dissection, and then we won't, the pathologist will tell us, no, you didn't get that. And then Michael will nod and go, I'll find it for you in 3 months when you send the patient for another scan. So that's very annoying when these 4-millimeter lesions are still there. So what the Germans have done is try and take this a step forward and see, can we use this avidity, the fact that the biology of these cancers is very apparent on PSMA imaging, and develop some probes to do that. And this is from the current paper describing the whole philosophy behind injecting PSMA-guided ligands or indium, and then using a combination of acoustic and visual probes to try and help the surgeons dissect these lesions out. And what you see here is an open salvage prostatectomy being done by Tobias Maurer when we visited him last year, and following injection of the radioisotope beforehand, it's helping identify these lesions in really quite difficult to access spots deep down in the pelvis. And then they have a confirmatory assessment once the lymph nodes are taken out. And there's no noise from the first sample, but here from this sample, which has been localized to the right internal iliac, you can tell, yes, you've got a positive node in there. Because it's very, very difficult, even with fancy robot surgery and all that, for us to identify truly avid disease. So I think this is exciting. I think if we are going to chase these little buggers, we should use your assistance to drive these radio-guided surgery things. And this is their results. So the top graph looks great. This is the PSA response. You do a salvage node dissection, radiosurgery guided. Yes, the PSA is coming down. But watch what happens to the Kaplan-Meiers. And this, again, I think underlies this whole approach to metastases-directed therapy or oligometastatic-directed therapy. They tend to all go on and get biochemical recurrence after a period of time. And I blame a lot of you for this, by the way. We're very enthusiastic at doing surgery, but I was in this very conference hall 2 years ago at the World Theranostics meeting, which Michael invited me to. And this was the logo. This was the byline for the meeting. If you can see it, you can treat it. Okay? But should you? I think you shouldn't be encouraging us. Surgeons and radiation oncologists already don't need much encouragement to treat lumps or to cut out lumps and so on. So I think we do need to try and challenge ourselves. Think just because we can see it doesn't mean that we should treat it. What do the guidelines say? And finishing on this topic before we finish up shortly, the current EAU guidelines say that this is experimental. We call this now MDT, metastasis-directed therapy, and should really only be done in the context of a prospective study. And there has been, by the way, a very nice prospective study published from the Belgians this year called the STOMP study, published in JCO a few months ago, which I was a reviewer for. And it did show that the time to castration therapy was delayed by having a metastasis-directed therapy approach, but it wasn't statistically significant. So I think we still need to challenge ourselves. Does it make a difference to chase these things, even in the exciting area of better imaging? Finally, what about primary staging? So we've been mostly talking about recurrence because it's such a big issue in prostate cancer, tens of thousands of patients. What about primary staging? And Michael is talking about the challenges of doing clinical trials here at this Congress, but this is a very interesting study that's recruiting very well. It's something that's badly needed, a prospective randomized study of conventional imaging versus PET imaging for patients with high-risk localized prostate cancer. So they've got features that make us think, right, they're going to need treatment, but they also have a reasonably high chance of recurrence down the line, like these examples we've shown you. But based on conventional imaging, they often have M0, N0 disease status. So we're recruiting these patients into this study, and then they're randomized to have either conventional imaging first or PET imaging, and they cross over. So you get the quality of comparing one type of imaging with another, and then we get the disease impact, which is being prospectively recorded. And here's a patient from the study just this very week. In fact, we had a whole run of them yesterday morning, on Thursday morning, when we sit in our tumor board at Peter Mac. We had 4 pro-PSMA cases being discussed, and here's one of them, 46-year-old, PSA 14, which is very high. It's very suspicious for a very nasty cancer. Felt abnormal. MRI scan showed a very obvious lesion. And he'd had a biopsy done elsewhere that showed grade group 5 cancer, which is the old-fashioned Gleason 9 or 10, very aggressive prostate cancer, but very fit 46-year-old. So we recruited him into the pro-PSMA study, and his CT and bone scan are normal. So we see no lymph node disease, no bone metastases. So therefore, he's clearly someone who we would offer either surgery or radiation therapy for his localized disease. But unfortunately, his PSMA PET CT tells us a totally different story. We see a very large avid lesion in the prostate here. This is prostate. And then we see all these retroperitoneal nodes that look enormous, actually, on PET imaging, but by CT criteria, all less than 10 millimeters in size. And not just a few nodes in the pelvis that we might still consider surgery with extended node dissection, but going right up to L4. So this is, very impactful, and, this is quite controversial. In fact, we shared this one on Twitter during the week because we have lots of thousands of followers on Twitter, and we share some of these cases with patients' permission. So I've got people from MD Anderson and Stampede Study and everyone saying, do this, do that, do it. But in the old days, that patient would have treatment. And maybe he should still have treatment. So we have to be careful not to throw the baby out with the bathwater just because fancy new technology that you guys have developed is showing us undoubtedly, I believe, the real state of disease, because some of these patients still need local control, blah, blah, blah. Anyway, what do you do? It's very positive. So these are difficult conversations with patients. And this particular study doesn't mandate what you do. It just records the decision impact. So I think this will be very, very important 300-person study. Also, let's just remember that 5% of prostate cancers thereabouts don't express PSMA, and I'll show you an example of that. This is a very ugly-looking MRI scan in a 59-year-old patient of mine, clinically T3. I biopsied him, and again, it's grade group 5, all cores, so very nasty cancer. He had a conventional staging CT and bone scan. This was before the randomized study. And he's got these lesions, multiple lung lesions, not a smoker. So the question is, well, could that be prostate cancer that skipped all the way up here, or could it be a second primary? So we do a PET scan. But his PET scan is completely normal, including no uptake in the prostate. So again, we went and did a VATS lobectomy, and what he's got is the same thing, prostate cancer in the chest. And we stain all these for PSMA, and there's no PSMA or very little PSMA expression. So don't forget that. There are 5% of cancers, including some pretty nasty ones, not low-grade ones, like this is a nasty one, that don't express PSMA for whatever reason. And also, there's a few curveballs I want to finish on. So this is very annoying when you come into the MDT and Michael says, what about that mesorectal node? And we go, mesorectal? God, prostate cancer doesn't go down around the rectum, does it? And we don't do node dissections down around the back of the rectum. We go up the internal iliac and external iliac. But no, unfortunately, in this era we're in, we see not just the left supraclaviculars, but we also see these lesions down around the rectum. So what does that mean? If you see a 5-millimeter lesion around the rectum, should the patient not have surgery or radiation? So it will be a recurrence, undoubtedly. So this is a new landscape that we're having to navigate due to the PET imaging showing us this surprising disease. And finally, what about lymph nodes? Louise may speak about this a little more, but I'll draw your attention to, again, the Munich group who did a nice study comparing, sort of man I've shown you, primary staging being put forward for surgery plus node dissection. And conventional imaging fails us badly here, really. We know that if the imaging's normal, but they have high-risk features, and you take out the nodes, you're going to see positive nodes in a significant percentage of patients. So what they did was do that prospectively, 130 patients with high-risk features, and they had a PSMA scan, either CT or MR, because they have an MR in their center, analyzed the conventional imaging and the PET components separately, blinded to see what additional value was added, and then did an extended node dissection. So what did they find? Well, they took out lots of lymph nodes, about 21. And what you see here is the extra value that PSMA added to these patients having a node dissection. So you see that the proportion of positive patients rises up as the area under the curve rises here in the PET arm. So it certainly performs a lot better than PSMA. Still miss a few, mind you. There'll still be a few cases who will have positive nodes, but will have no avidity on a PET scan. And they conclude that it's superior to conventional imaging and should replace it. And the pro-PSMA study, a lot of it's about that. It's what's happening in the prostate, but particularly what's happening in the lymph node drainage basins. So my take-home messages on primary staging: this is undoubtedly already changing many high-risk prostate cancers from N0, M0 into N1, M1. And along with that comes significant impact on our decisions and advice to patients, which we need to be a little bit careful about, not throwing out all the data we have for primary treatment. We do need better tissue validation, and we are carefully assessing the decision impact. So finally, I think, as I've said to you at the start, conventional imaging fails us, even MR fails us, and we, as cancer specialists, need to move beyond just identifying these little lumps in patients, either at primary staging or in the recurrent setting, and better characterizing them. We have to move beyond the lumpology that Hicks and Hoffman have spoken about. And undoubtedly, the advent of PSMA PET in particular, and the various types of PSMA that you're now offering us, has added a significant impact to our treatment landscape, which is very welcome, by the way. I think we do need to get better prospective studies, in particular around decision impact, and we need to work together with your community and ours to set up those studies and get them funded. And we are excited about the image-guided and theranostic possibilities that we never really had with conventional imaging, because of all your own experience in theranostics and sentinel-guided approaches. I think this is very exciting for us in the prostate cancer world to be working closely with you. And that's my final message. I think we, as clinicians working in prostate cancer, are very excited to work with you on this, and I thank you again for the invitation.
Thank you, Declan, for that excellent talk. We've got a clock up here, and he kept to time to the second. That's very, very impressive. Declan, can you just come back up for a moment? We've got a small certificate of appreciation to present to you.
Thank you, Michael. Great, thank you. Appreciate it. Thanks, Hussein. Thanks, Michael.
Okay, moving on. Our second speaker is Professor Louise Emmett from St. Vincent Hospital in Sydney. She's a nuclear medicine physician, and her talk is entitled PET-CT and PET-MRI in Prostate and Urological Malignancy. Professor Emmett.
Well, first of all, thanks very much for asking me to talk today on a very interesting subject. In fact, when I was developing this talk, PET-CT and PET-MRI and urological malignancy just seemed way too broad, and it's been such disruptive technology in the last 5 years, I decided to hone it down just to prostate, like Declan. And these are my disclosures. So basically, the last 5 years have seen dramatic change in what we're doing with prostate cancer. And if we look to the old technology, this is a patient that we were imaging for a lutetium PSMA trial to look for eligibility. And this is the bone scan compared to the PSMA PET that you can see here. And if you're reporting that bone scan as a nuclear medicine physician, it's really very difficult for us to say. You can say that that patient's got irregularities on their bone scan. It looks like they've either got metabolic bone disease or they've got disseminated metastatic disease, but you can't say how much, and it's impossible to quantify. Very difficult to look for progression. In contrast, if you look at this PSMA PET scan, it's you can identify whether there's disease in bone, viscera, whether it's in lymph nodes. You get an idea of intensity. You can characterize the phenotype, and you can quantify very nicely the pattern and volume of disease. So really, a great leap forward for us. So PSMA is a really good target for imaging and also for therapy for us in prostate cancer. Its real name is glutamate carboxypeptidase type 2, and it's actually a transmembrane glycoprotein that's expressed in normal human prostate epithelium, but obviously overexpressed about 1,000 times in prostate cancers. It's got both an internal an intracellular and extracellular component, so it's very good for labelling and also for getting dose into the cell. And its expression conveniently increases in poorly differentiated metastatic and castrate-resistant prostate cancers with a very nice inverted relationship to androgen levels. I think it's really important that we understand that it's not just a target for imaging in prostate cancer, but it has a very important role in the cell itself. And this is a very nice paper that was published earlier this year looking at the role of the PSMA receptor within the prostate cancer. So it actually has a direct effect on the PI3K pathway via glutamate release, which is an oncogenic signalling role and actively promotes cell proliferation. And PI3K pathway is actually a pathway known very well by oncologists, and they use it for treatment. So if you inhibit the PSMA function within the prostate cancer cell, you actually cause tumour regression in mouse PSMA expressing xenotypes. Further, this very nice article showed the strong relationship between the androgen receptor, the PI3K pathway, and the PSMA receptor, which is reciprocal. We've known for a while that if you manipulate the androgen receptor, you actually get upregulation of the PSMA receptor, and hence you can see more on the scans. But what I hadn't realised before reading this pathway is that it's reciprocal as well. The PI3K pathway actually has quite a strong effect on the androgen receptor, and I think that's going to play a very important role in how we map out treatments and also how we should interpret the scans that we see. So the advent of the small molecule peptides has really caused an explosion of PSMA PET, or perhaps a plague, as Declan says, of PSMA PET imaging, certainly in Australia, with their fantastic extracellular binding, rapid internalisation, fast blood clearance, low background activity, and high image quality on PET imaging. And certainly for us, we started using the PSMA 11 in 2014, gallium PSMA 11, and we still are doing that, but there's just such a large number of F18 and gallium PSMA ligands that you can use now, PSMA INT, and the new hybrids that Hans-Jürgen Vester was talking about yesterday, where you can label it to both gallium and fluorine. DFC PYLs are increasingly used in Australia with the advantages of fluorination and delayed imaging. And F18 PSMA 1007 also looks very interesting for its minimal renal excretion. It's fluorinated, you can do delayed imaging, and should be very nice looking in biochemical recurrence without the problems of bladder activity. And I think that we're all really learning about prostate cancer as nuclear medicine physicians, and there's so many new tracer agents that have different biodistributions, different quantification. We need to develop standardised methods of reporting, and it's really nice to see that there's a few articles coming out specifically about that, and some of them showing some very nice, clean ways that we can report these new tracer agents. So the meta-analysis that was published by the Melbourne group, and Declan's already spoken about, gives us a nice idea as to how effective PSMA PET has been to date in a number of articles, 1,309 patients. So 40% of scans were positive for extraprostatic disease for primary staging, and about 76% of scans positive in biochemical recurrence. So really a very high level of detection with PSMA PET, and a sensitivity of 80% with a specificity of 97%. People talk a lot about how prostate-specific membrane antigen's probably been mislabeled. We shouldn't call it prostate-specific membrane antigen because it gets taken up in a lot of other tumours, and that's correct. However, when you look at the data in staging and in biochemical recurrence, that specificity of 97%, specific to the questions that are being asked in prostate cancer, stands strong. It is very specific. You do get significant uptake in neovascular of solid tumours in a number of other cancers, and particularly in clear cell renal cancer. It's looking very nice. And this is a patient who turned up for imaging of their prostate cancer and had the incidental renal cell cancer found. Thyroid cancer, glioma, colorectal. I saw an article on breast the other day, so it's going to be very nice to see how it can be expanded into other agents. We have to be very careful how we report, and we have to report appropriately for the patient. This is actually a scan in one of our prospective trials where the patient had a radical prostatectomy, was staged prior to the radical prostatectomy, and because we had a scan that was positive prior to the radical prostatectomy for distant disease, they turned up 6 weeks later for repeat PET imaging as a result of the trial procedure. And I was perplexed because suddenly, it was a Gleason 9 prostate cancer. The patient had quite aggressive disease, but suddenly they had bone lesions. In fact, he fell out of the second floor of his second floor window onto concrete 2 days after his radical prostatectomy, and these are new fractures, so ouch. But fractures also take up PSMA PET, it's neovasculature, and we need to be very aware of that in a report and context. So the meta-analysis, and Declan's shown this, showed very nice detection rates at very low PSA levels, which is something that we hadn't previously seen with choline, and up to 42% of patients get a positive scan with biochemical recurrence with a PSA of less than 0.2. And the question is how we use that. We did a prospective head-on comparison study between choline and PSMA in 2014-2015 when we were first starting PSMA PET. And it shows very nicely at very low PSA levels, if you have a PSA of less than 0.5 nanograms per mil, you'll only get a pickup rate of 12.5% with choline versus 50% with PSMA. So very high detection levels at low PSA levels. But how good is it for staging and diagnosis of prostate cancer, and what is actually the evidence for that at the moment? We have evidence for management impact that was published earlier this year with a multi-site prospective study from Australia by Paul Roach and the ArtNet group. So 431 men undergoing PSMA PET for prostate cancer. 108 of those men actually were for staging for intermediate and high-risk disease. Overall, it found a management impact for PSMA PET of 51% for biochemical recurrence and for primary staging. And in the primary staging group, impact was about 21%. So 21% of men who had PSMA PET prior to primary staging had a change in management as a result of it. And up to 30% of those men actually had disease identified outside the prostate on staging PSMA PET. So it's looking promising. And certainly the PRO-PSMA study, which you've heard about from Declan and being run by Michael, will answer a lot of questions about how clinically relevant PSMA PET is prior to staging, both to radical prostatectomy and to radiotherapy in this nice randomised multi-centre trial that's currently underway. We're going to get a lot of information on accuracy, also a lot of information on management impact, health economics, radiation exposure, and many, many other things that it can look at. But we do have some prospective data. This is a study that was published in Australia in 2017, looking at the ability of PSMA PET or the diagnostic accuracy of PSMA PET prior to radical prostatectomy in staging lymph nodes. 30 men with high-risk prostate cancer were prospectively enrolled and consented. They had to have a greater than 5% clinical risk of lymph nodal involvement, and patients all underwent an extended lymph node dissection with a large number of nodes dissected per patient. So 100% of those patients actually had PSMA-positive disease in the primary tumour in this study. There were 536 lymph nodes that were resected, 4.9% of which were harbouring metastases. And when you look at that in terms of sensitivity and specificity on a per-patient analysis, specificity was very high, as has been shown repeatedly. But the sensitivity per patient was only 64%, so it was actually a little bit disappointing. It's actually very similar to the choline studies in terms of sensitivity. And when you looked at the node analysis, it was only 58% on a nodal rather than a per-patient basis. Why was that? And when you look, so this is one of the positive patients on the trial. This is a 7mm lymph node that was identified as a true positive both on histopathology and on the PSMA PET. But this is what we missed. So these are the two 1.8mm lymph nodes on the other side that even with retrospectoscope we just can't see. So well below the spatial resolution of a PET, and more than half the lymph nodes identified in this trial were well below 1 centimetre. So in fact the mean false negative node size in this study was 2.7mm, very, very small. And the mean true positive node size was 4.2mm. So once again, the mean true positive node size was also well below the spatial resolution of the PET. So it's punching well above its capabilities. And when we looked at the size of nodes and detection rate, we picked up 0% of nodes that were between 0.1 and 1.9 millimetres, 60% of nodes that were between 2 and 4.9 millimetres, and 86% of nodes that were greater than 5 millimetres. And it's really interesting as to what that actually means to the patient. If you can detect 1 millimetre lymph nodes, is that better than if you can detect 3 millimetre lymph nodes? And what happens when we get down to a cellular level? And I think that some of this becomes more interesting when you consider the biopredictive capabilities of PSMA PET. So this is a complex slide, and I'm sorry about that, and it relates to a study that we've been doing in 142 men who we've analysed prior to radical prostatectomy, looking to see whether PSMA PET can actually predict biochemical response. That is a complete response to surgery with PSA of less than or equal to 0.02 postoperatively, and whether and how good it is at doing that. And so what this study is, this is looking in lymph nodes specifically. It's looking when the histology, so if the histopathology was positive within the lymph node versus whether we were positive on the PET scan and whether there was a biochemical response. If you look at the patients who've got a PSMA positive for lymph nodes on the scan and their histology positive, patients do very poorly. There's only a 14% response or complete metabolic response, independent of whether they had a lymph node dissection to surgery. The interesting thing is we missed quite a few nodes on the PSMA PET. But when you look at the scans that are PSMA negative and they're histology positive, so we know that those lymph nodes actually have cancer within them, they actually have a really good treatment response to surgery, almost as if they had histology negative lymph nodes and negative PSMA PET, in which the majority of patients did extremely well. And when you look at that in a different form, you can actually see that histology here is for the lymph nodes is positive, but what really stratifies the patients is whether they were PSMA lymph node positive or not. And I wonder whether the histology that is negative or PSMA negative is perhaps a different phenotype to those that are positive, and that there's quite a strong predictive biomarker input into this. And this is something that I think something like the PRO-PSMA study can definitely look at, and to see whether we have some predictive capabilities beyond just histopathology. Is PSMA better than histopathology at staging? And we need to look into that more. So looking at within the prostate itself, how good are we at looking at within the prostate itself? And this is a study that was published in 2015, very early, by Tobias Maurer and Matthias Eiber in Munich. So 53 patients who'd had radical prostatectomy that had PSMA PET and MRI higher. It was a high-risk cohort. And what it found was when they looked at the MRI detection rate for intraprostatic malignancy, it was 66%. They didn't include the PIRADS 3 group. PSMA PET picked up 92% of men, and there was a good synergistic value in the detection of intraprostatic malignancy with both PSMA and MRI. I think this is very interesting in context of what we're actually doing with diagnosis of prostate cancer with MRI, where we're moving from everyone getting biopsies to trying to stratify patients by MRI as to whether they need a biopsy for the diagnosis of prostate cancer or not. And the Precision trial and the Promise trial have provided a lot of information about that in the last year or two. So Promise trial looked at 576 patients. It was a prospective paired cohort study in men with an elevated PSA but no prior biopsy, and it compared MP-MRI, truss biopsy and template biopsy. And what it found was a very nice sensitivity for the diagnosis of prostate cancer, but specificity was just 41%, and as a result of the specificity, the positive predictive value is 51%. What that means is a high percentage of men end up having a biopsy that they don't need. And the really interesting question is there a role for PSMA PET in identifying significant cancers, so cancers that have an ISUP2 or greater pattern of malignancy, and dictating the need for biopsy in men with PIRADS 3 and 4 disease. And this is a study we've done in 54 men with intermediate risk prostate cancer using a 12-segment model for ISUP1, trying to differentiate between ISUP1 disease or Gleason score 3 and ISUP2, which is Gleason score 4 or higher, between MRI and PSMA. And what we found was, comparing the PSMA PET to the MRI, PIRADS 4-5 or MRI 3-5, that there was a very high sensitivity and a very high specificity of PSMA PET intraprostatically for the detection of significant malignancy, so pattern 4 disease on histopathology, compared to MRI at 56% and 68% depending on the PIRADS that you use. So potentially it could have a very nice role, and we need to look at that in prospective settings. So biochemical failure is really the group that we've been doing a lot of imaging in Australia, and it's because salvage radiotherapy hits the target only 50% of the time. I mean, that being said, 50% of men who have salvage radiotherapy are actually cured and have no further problems with their prostate cancer. This is the very first scan that I ever did with, as part of a prospective trial that we were doing, a head-on comparison. It was a really exciting moment to be able to identify an obturator node in a man who had a rising PSA following a radical prostatectomy. The fluorocholine was negative. However, very disappointing, he went for lymph node dissection, came back 6 months later, and just like Declan was saying, PSA hadn't changed at all, and we identified 2 further nodes directly superior to the lymph node dissection site. And so in Declan's words, this patient was pokemetted. We didn't help him at all. He underwent a significant procedure, and I hope I got the grammar of that correct. Yeah. But we have found a lot about prostate cancer. This is in biochemical recurrence. We're getting increasing information on how we should use it. So this is looking at detection rates in 70 men with a PSA of less than 1 who are eligible for salvage phosphoradiotherapy. What we discovered is about 50% of patients have disease outside of the prostate fossa at the time that they turn up for their salvage phosphoradiotherapy. So a significant proportion of men will not benefit from salvage phosphoradiotherapy alone. And I'm really proud to be able to present some initial data from our PROPS trial, which is a multi-site international prospective trial in high-risk men with negative conventional imaging, evaluating the ability of choline, PSMA and MRI to stratify high-risk patients who will respond to salvage phosphoradiotherapy. So it was spread across Australia, Canada and Britain. 91 men were enrolled across 9 sites prospectively. Men had to have negative or conventional imaging. All imaging, both the PET and the MRI, was undertaken within 2 weeks of each other. And we had to scramble very fast in this trial. We started this trial in 2013. 2014, we had the tsunami of PSMA overtake us, and we were able to stop the trial, introduce gallium PSMA in addition to choline in the Australian sites, and then keep going. So we had all imaging results, biopsies, management impact and treatment outcomes documented for up to 3 years following enrolment. And this is the patient characteristics. So median PSA at the time of imaging was 0.42. These patients were all high risk on Stevenson nomograms, so the doubling time was extremely fast at 5 months with relatively high Gleason score 8 to 10 disease in this patient cohort. So what have we found when we have consensus read all the MRI, the choline and the PSMA? What we did find was PSMA. So we found that MRI has quite a high detection within the prostate fossa, but very low detection distantly. Fluorocholine had the lowest detection within the fossa, but quite good detection distantly, and PSMA reasonable detection within the fossa, almost comparable to MRI, and highest detection distantly within lymph nodes and bone. When you look at the two together, the total detection rate for MRI overall was 28% of patients, 32% for fluorocholine, and 42% for PSMA. That was also reflected in the... So that correlated also to the sensitivity and specificity, so very high specificity for all modalities, using a combination of treatment response to targeted therapy and biopsy as a gold standard for accuracy. MRI detection rate was, or sensitivity of 19%, close to 50% for fluorocholine, and 67% for PSMA in this biochemical recurrence setting. This is the Stevenson nomogram, and it's a nomogram very well known to radiation oncologists. They determine patients' likelihood of responding to salvage phosphoradiotherapy based on patient risk. So it ranges from 18% in high-risk patients up to 81% in lower-risk patients. This is a patient from the PROPS trial, so a Gleason score 8 prostate cancer, positive margins, 5 years post-radical prostatectomy with a rapid doubling time and a PSA of 0.27. And what you can see here, we've got a fluorocholine positive, MR positive, PSMA positive recurrence, which responded very nicely to salvage phosphoradiotherapy. Sorry, it's not changing. So on the Stevenson nomogram, if you work it out, that patient had an approximately 37% risk of recurrence. But when you look at the other images on the scans that we've got, we actually have a MRI negative, fluorocholine negative, PSMA positive bone metastasis in this patient. Sorry, it's not changing again. Can someone just manually change that for me, please? Next slide. Thank you. So on the clinical nomogram, if we're working out that risk, the patient's got a Gleason score 8 prostate cancer. What's their chance of cure with prostate phosphoradiotherapy is about 37%. If we look at PROPS imaging assessment with a PSMA fluorocholine MRI positive local recurrence and a PSMA positive MRI negative fluorocholine negative bone lesion, chance of cure with salvage phosphoradiotherapy is 0%, and chance of cure with prostate phosphor and bone radiotherapy is totally unknown and fits within the oligometastatic setting. The detection rate for extrafossa disease correlates completely to the patient's treatment responses by modality. So when we look at PSMA versus fluorocholine versus MRI, PSMA is very well able to stratify patients who are going to have a treatment response versus patients who will not have a treatment response. In the, if you have a negative scan or if you have disease confined to the fossa and you have on your PSMA PET, 87% of those patients will have a very good treatment response to salvage radiotherapy versus 14% if you have distant disease identified. Much less able to do that with MRI with fluorocholine somewhere in between. So I think this is a cutout from Matisse, one of his very famous paintings when he was older and was having trouble with a paintbrush from arthritis, and he was very interested in negative spaces. And I think this is something we should be considering a lot in our reporting and also in how we decide how to manage these patients. This is a study that we published last year in 164 men looking at treatment outcomes following salvage radiotherapy. All these men had a rising PSA post-prostatectomy with a PSA of between 0.05 and 1 and a median follow-up of 11 months. The treatment documented included whether the patients had ADT or not and the radiotherapy site and dose. We also documented treatment response, looking at PSA, and treatment response was defined as a PSA of less than 0.1 nanograms per mil with a greater than 50% decline in response to targeted therapy. With some really interesting results, what it showed was up to 39% of men who had a PSMA PET had a negative scan. 44% of these men underwent standard of care salvage radiation therapy. 56% of these men did not. In fact, there was no difference in the risk factors between the two cohorts, and 100% of men who had fossa or PSMA positive disease in the fossa actually had salvage radiotherapy. So certainly we were influencing, as a result of our reports, whether patients underwent therapy or not. What was even more significant was the treatment responses. So if you had a negative scan and you underwent salvage phosphoradiotherapy, 86% of you actually had a really good treatment response. In contrast, if you didn't get salvage phosphoradiotherapy with a negative scan, 65% of those men actually had a rising PSA. A number of them rose well beyond curative levels. So when we look at that by scan result, if you had a negative PSMA PET, 86% treatment response. If you had disease confined to the fossa, 81% treatment response. If you had pelvic nodal involvement and they received radiotherapy in addition to the fossa, 61% treatment response. And if you had distant disease on the PSMA PET, 30% treatment response. And there was an inverse relationship to the extent of radiotherapy. So the bigger, more complex the radiotherapy fields, the worse the patient actually did. And PSMA PET was the most predictive indicator of whether a patient was going to respond or not, including a lot of markers from the Stevenson nomogram, PSA, T-stage, Gleason score, and surgical margins. So from this trial, we found that men with biochemical failure following radical prostatectomy and a negative PSMA PET scan are the men who are most likely to have a marked biochemical response to salvage radiotherapy, and yet the least likely to actually receive the treatment. And I think that's something that we really need to address in what we're doing and how we're reporting and how we're educating referrers about the significance of these scans. So metastatic castrate-resistant prostate cancer, it's really an evolving space. It's something we're definitely using PSMA PET for, particularly for the screening and response prediction for PSMA-targeted therapy like lutetium PSMA. And this is one of the patients, a significant proportion of patients at the end stage of their disease, 10 to 20% won't have a significant amount of PSMA receptor on their cells. And this is a patient with a PSMA negative but FDG positive scan who was not eligible for one of our trials. In contrast, this patient has very intense PSMA-avid disease with the FDG avidity far less intense, which is something that we really like to see if patients going for lutetium PSMA therapy. And that does have a direct correlation to treatment response. If you have, on a PSMA PET scan, if you have intense disease, you actually can predict whether you're going to get a greater than 25% response to lutetium PSMA, though it's not predictive of an exceptional response. And finally, I just want to finish up with this very, very interesting thing that happens with PSMA PET when you add in androgen receptor manipulation. So the FOLH1 gene encodes the PSMA PET protein, and FOLH1 is suppressed by androgen. So if you give testosterone, you actually suppress messenger RNA and FOLH1 activity, and you probably suppress activity on a PSMA PET scan. Androgen blockers such as LHRH, Cosidex, and novel anti-androgens competitively inhibit the androgen binding to the androgen receptor, and FOLH1 is switched on. And if you look in mice xenotypes and cell lines, you actually get a dramatic upregulation of PSMA receptor in response to androgen deprivation therapy. And this was shown very, very nicely in a study by Thomas Hope, where in a single patient doing a day 0 and a day 28 scan, had a dramatic increase in the PSMA receptor density. So what you can see here is the day 0 scan prior to starting hormones and day 28 after starting hormones. PSA is decreased from 66 down to 9, so very good treatment response. But there's been a dramatic increase in the number of lesions that you can see. So twice a significant number of lesions more, and a 600% increase in PSMA SUV max or intensity on the scan. I think that when we're reporting treatment responses and when we're reporting in the castrate-resistant setting, we really need to be very aware of the fact that the androgen has this very strong effect on the image. And quite often I see people reporting progressive disease, and we need to know what's happening with the androgen receptor. Have they started on androgen receptor? How long ago did they start on the androgen receptor? And could it possibly be causing this effect? And that's all. Thank you.
Thank you very much, Professor Emmett. Just to let you know that there is also a certificate of appreciation for your participation. However, it's going to be given to you at tonight's president dinner. So same thing goes for our next speaker, Dr. Richard Baum. So the next speaker is, as I said, Dr. Richard Baum, who is the chairman and clinical director of the Zentral Clinic in Bad Berka in Germany. And the title of his talk is The Power of Precision Oncology, Improved Overall Survival After 5 Years of PSMA Radioligand Therapy in Greater than 200 Prostate Cancer Patients. Richard?
Thank you very much for the kind introduction. Ladies and gentlemen, dear colleagues, it's a great pleasure to be here and to report now on therapy. So we will switch gears from diagnosis to therapy. And I will like to start with a definition of precision oncology and personalized medicine. And I would like to remind you, and this is especially true if you are treating patients, that everything starts with patient history. It's not only looking at images, it's interacting with the patient, taking actively history. But what you also have to know nowadays, of course, is a lot of proteomics, metabolomics, gene expression profiling, and all these things. And if you bring all this together and use PET-CT and PET-MR for multimodal imaging, we can get better information and get earlier diagnosis, better risk assessment, therapy selection and monitoring, and even in future, I think we can have an impact on epidemiology and prevention of the disease. So precision oncology means that cancers will be classified in future by molecular phenotypes, and that the organ site is actually a secondary classification. So we will not speak about breast cancer, colon cancer, prostate cancer, and so on, but we look at molecular phenotypes, and this can be determined, of course, by molecular pathology, what is done today already in many instances, especially in breast cancer and lung cancer and so on, but also by molecular imaging using cancer-specific probes. And we will use PET, and we are using PET and SPECT for doing this, and treatment then will be targeted specifically against the tumor, and this is what we call precision oncology. So I think nuclear medicine is in the unique position that nowadays we already apply precision oncology. Others are speaking about it, but we are already doing it. And I think prostate cancer is a paradigm for this approach, as molecular radiotherapy is applied based on the molecular phenotype, namely PSMA expression of metastases as defined by PSMA PET-CT before starting treatment. So we can come from trial and error medicine to personalized medicine. So usually you treat a patient and then you re-evaluate the patient, let's say by CT or MRI 3 months later, and then you find the patient has a response or he has not a response. So this is trial and error, but we can break this cycle by inserting an imaging test, PET-CT, and then do a determined action and get a predictable response. So I think targeted radionuclide therapy has really unique promise for personalized treatment of cancer, because both the targeting vehicle and the radionuclide can be tailored to the individual patient. Coming to prostate cancer, you all know that there have been a lot of progression over the last years with new drugs like abiraterone and enzalutamide, which have been introduced, but and also, of course, radium-223. But all these patients, unfortunately, still die if they have progressive metastatic hormone-resistant prostate cancer. And this is a very busy slide and summarizing the results of the trials with chemotherapy and these new anti-hormonal drugs in the Journal of Clinical Oncology. And to make a summary of this data, survival benefit with chemotherapy is just 9 to 10 weeks. Though it's not a very long time, actually, patients gain by treatment with chemotherapy. And second generation ADT just adds about 3 to 5 months to the patient. So in early staging of disease, progression-free survival ranges from 6.5 to 18 months, and overall survival from 14 to 32 months. Please remember these numbers, though there is an urgent need for more effective therapies. Now, in 2018, docetaxel-based therapy is a standard first-line chemotherapy applied in patients with mCRPC. There's a poor prognosis of this patient, as I just mentioned, and the median overall survival is just 14 months. And chemotherapy has really a lot of adverse effects on the central nervous system, on the skin, on the gastrointestinal tract, but mainly on the hematological system. If you look here, you see that the number of neutropenias, for example, grade 4, 75%, and so on. But it also has hypersensitivity reactions, neuromuscular and skeletal adverse effects, and so on and so on. So, and it's even worse with cabazitaxel, which just has a benefit of 2.4 months in overall survival when you compare it to mitoxantrone chemotherapy, which was used in earlier times. And the number of anemia is 98%, and of them grade 3, 4, 11%, and leukocytopenia 96%. So please remember these numbers if we come to PSMA radionuclide therapy. Even if you have sometimes some hematological effects, it's much better than the chemotherapies. And novel therapies has also some shortcomings. Some are only available in US or in Europe. PSA is not really very useful for monitoring the disease, especially in undifferentiated cancers. The sequence of the therapies is not clear at all. If you do first chemotherapy and then the newer ADTs or vice versa, and there is a lot of toxicity, as I have just shown, also financial toxicity, because some of these treatments are very, very expensive, some even over $200,000 you spend. So you have a Rolls Royce, but it's really not nice for the patient to drive this Rolls Royce. If you look at the cost in Germany, for example, for enzalutamide, which is about 60,000 euro or $70,000 per year, and abiraterone is around 66,000 euro or $77,000 per year. So these drugs are not cheap at all. Now, theranostic pairs for precision oncology, you know that we have our target on the tumor cell, which works like a lock. And in this case, it's a PSMA molecule. And then we add the urea ligand, the PSMA ligand, to our lock. And we can have a linker and a chelator, which holds then our diagnostic radioisotope labeled with gallium or fluorine or copper or other interesting radioisotopes. Also, for gamma camera imaging, technetium-99m was mentioned and is used, for example, in Germany in quite a number of centers not having PET available. But we also can use this chelator for binding lutetium-177 or alpha emitters to our ligand. Now, you heard already about PSMA, and Henry Wagner once said, FDG is a molecule of the century, and I think PSMA is at least the target of this decade. And this is especially true because the expression increases progressively in higher grade tumors, in metastatic disease, and in hormone refractory prostate cancer. And this was shown by a large number of immunohistochemical studies, which are listed here. This is a slide by Neil Bender. And look at the numbers, nearly 1,000 patients studied, and there was a very high expression, especially in the higher Gleason grades, as you can see here. And the advantage is that BPA, benign prostate hyperplasia, is negative. In Germany, we were quite early to define a protocol, a consensus guideline for treatment of metastatic prostate cancer. And there were already some data published in the journal last year, especially on also improvement pain and quality of life in these patients. And following this initial guidelines, there are now a number of publications. You do not need to read that. It's just to get you an impression how many papers have come out now on this therapy. Now, in our center, we were using dosimetry, especially if we were using new PSMA ligands. We performed individualized dosimetry, and we found a great intra-patient variability due to tumor response, but also varying tumor load between different therapy cycles. And we did also an analysis between PSMA INT, the imaging and therapy compound from Munich, and the PSMA 617 from Heidelberg. And we found quite comparable results for both ligands. The highest dose to normal organs is to the lacrimal and salivary glands and the kidneys, as shown here. And what is very important that red marrow receives only a very low dose of about 0.01 to 0.04 gray per gigabecquerel when we inject it. Now, in June 2016, we published our first results, actually, in 56 patients using PSMA INT, and there were striking results, like in this case here shown, with a lot of disease in the bone and the lymph nodes and a complete response after therapy. At that time, we did not have overall survival, but we had a median progression-free survival of 14 months. And please compare this to the data I have shown you for chemotherapy. We also looked at molecular response, and you just heard that PET can not only be used to define the disease and to select the patients, but also to evaluate response to the treatment. And it's quite similar what we have seen with the molecular response and the PSA response. So our concept is that we restage the patients by PET-CT, looking at the molecular and the CT response. So if we have stable disease and the objective response, we just observe and follow up the patient. And we, of course, also monitor the laboratory parameters like CBC, renal and liver panel, and the PSA. And then if there is new progression of the disease, we treat the patient again, what we call now treatment phases. So the first phase is 2 or 3 cycles. And then if the patient is stable, we stop. And then we retreat in the second phase of treatment. These are our statistics. So until end of March this year, we have actually treated 254 patients with 762 treatment cycles. The mean administered activity was 6.2 gigabecquerel. And you see that most of the patients actually received 3 treatment cycles, but many had more treatment cycles, actually up to 12 of them. The mean age of the patient was 71 years. The mean Gleason score 8, so these were mostly undifferentiated cancers. Nearly all patients received ADT, many of them surgery, radiotherapy, chemotherapy, or other treatments like immunotherapy, as mentioned here. And these were really ill patients. If you look at the number of bone and bone marrow metastases, lymph node metastases, but also visceral disease, lung, for example, in 32, liver in 31 patients, and also quite rare localizations like pleuro-pericardial space, testicular metastasis, adrenal metastasis, as all found on the gallium-68 PSMA PET-CT. And many of these patients had combined disease, so not only bone, but also bone and lymph node metastases. And we are now in the process of analyzing all this data, because we have stored all this data in a database and looking what is the response in bone only, in lymph node only, and in combination of the disease. This is just one example of a patient with lymph node metastases, PSA 4.6 and a Gleason score 8. Though this patient had already received surgery, local salvage radiotherapy, and ADT, and the decision actually was made based on the recommendation of the oncologist to irradiate these lymph node metastases, which are in the para-aortic region and paracarpal region, as you can see here. Though the patient was treated by external beam radiation therapy, and actually 1 year later his PSA was 45, and he had disseminated metastases localized mainly in the bone and bone marrow. So we treated him with 2 cycles of PRLT, and fortunately enough, he received a complete remission with also biochemical complete remission and a PSA of 0 just after 2 cycles of therapy. These are the lutetium scan, which show that there is really a very extensive disease 20 hours and 70 hours after lutetium treatment. This is under the first therapy, and you see that there is an excellent response, which you can also see on the lutetium scans, so you can use also the post-therapy scans for defining therapy response to the treatment. And this is the PSA response of the patient. So any PSA decline was observed in 70% of the patients, and best response, as I have shown in several patients, was 0.0. And what is also very important in the oncological literature, that decrease in PSA by more than half was observed in 54% of the patients. What about safety, and especially kidney? Because as we have seen on the PET scan, the kidneys are very dark and receive quite a dose with lutetium. So we determined in all patients, of course, creatinine, we measured GFR. We did also MAX3, TER, tubular extraction rate measurement in all the patients before treatment and after therapy. And we have no evidence of nephrotoxicity without any nephroprotection in these patients. So I dare to say that really lutetium is not nephrotoxic. And since 2013, which is now 5 years, we have not seen any nephrotoxicity in long-term follow-up in over 200 patients treated with up to 11 cycles, including 15 patients with a single functioning kidney. Safety analysis, again, concerning hematological effects, anemia. We have seen some anemia before PILT in these patients, and there was only a small number where anemia was worsening. The same is true for leukocytopenia. As you can see here, we had 0 G4 toxicity and only 3 patients with grade 3 toxicity. And thrombocytopenia, we had actually 7 patients before treatment with G4 toxicity and only 1 with G4 after treatment with lutetium. So predisposing risk factors for higher grade hematological toxicity are prior chemotherapy, especially using cabazitaxel. Also, radium-223 dichloride therapy is reducing platelets long-term in some patients and is a risk factor, and extensive bone and bone marrow metastases can also pose a risk. There is no evidence of any radiation-induced hepatotoxicity, and we did not find any significant change in all these laboratory tests mentioned here. So to remind you again, survival benefit from currently recommended chemotherapy, hormonal therapy, and alpha-radin therapy is just in the range of a few months. Our data show that PFS for all these patients based on CT, on RECIST criteria, is 9.8 months, and overall survival is 30.9 months. This is, I think, really an impressive result. It's not a randomized trial, it's not multi-center, it's not prospective, it's a single-center trial. But I think these data already give a good hint that this therapy is really very effective. You heard about the influence of ADT on PSMA expression, and we compared the median overall survival in those patients under ADT, abiraterone or enzalutamide, and it was 14 months, and without treatment, significantly less than half, 19 months. So we strongly recommend in these patients to continue treatment with ADT, and also if there is an effect of abiraterone or enzalutamide, one has to evaluate. This is just one patient after 3 cycles of lutetium PILT, partial remission, but still a lot of lymph node metastases. He had a PFS in this stage of 13 months. So you do not need always to treat in these patients, but sometimes they are stable over a long period. And then he had progressive disease, and as you can see here, with also a lot of bone metastases. And then we treated him in combination with enzalutamide, and he had, again, a nice response to the treatment. What about chemotherapy? If you look in chemotherapy-naive patients, they have overall survival of 38 months, but those patients having received chemotherapy have just half the time of overall survival, 19 months, which is also statistically significant. And we need really randomized control studies to determine if we should place PILT before or after chemotherapy. Though this is one example of a 62-year-old internal medicine specialist. He had a lot of disease and a lot of pain, and he did refuse to receive chemotherapy. So we treated him with 3 cycles of PILT. As you can see already on the lutetium scans, he had a nice response to the treatment and finally received a complete remission after 3 cycles, which really lasted for quite a long time, and he could restart his practice as a doctor and is now playing regularly tennis. So it's not only that we improve images, that we see PSA decline, but it's also that we can improve a lot the quality of life in these patients. As you can see here, 17 months after start of PILT, he still is in complete remission. What about de novo radioligand therapy? That's how I name the first phase treatment after primary surgery or radiation therapy. So we are looking into this, and we have here listed 11 patients. As you can see, many of these patients had a older age and already received local treatment. And we have looked in these patients, so overall survival at 3 years is now 91%, so just 1 patient died, and the median follow-up is nearly 2 years now. The median progression-free survival was 30.9 months based on EORTC criteria as well as RECIST, and all patients demonstrated a decline in PSA, 50%, of more than 50% in 82% of the patient, and the median PSA progression-free survival was 20 months. So these data are really encouraging. We have seen that this therapy in a first-line setting is feasible, is safe and effective, and is very, very well tolerated. And I think, again, further studies, prospective studies, are really warranted. This is just a patient with a primary tumor, as you can see here. Okay. Very bulky lymph node metastases in the obturatorius region, and he was treated with lutetium PSMA, had a very nice response. The lymph node bulk decreased significantly, as well as a primary tumor. Absolutely no adverse effects. Therapy was very well tolerated. This is another patient with partial remission of the primary tumor and metastases after de novo lutetium PSMA radioligand treatment, and also mixed pattern after salvage treatment in combination with abiraterone. What about the alphas? There is at least one study running in South Africa, and Mike Satege was kindly enough to give me this case of a de novo treatment using actinium PSMA, bulky lymph node metastases. And as he said yesterday, this is not Photoshop, right? This is really the effect of just 2 cycles of actinium therapy, complete remission of the disease. So targeted alpha radiation therapy might be the future. And we have used, and again, Mike Satege has used bismuth 213 PSMA, which has shown some effect, for example, in lymph node metastases. In our group, the effect was only minor. And to summarize this data, bismuth is feasible in end stage, but it's also not very effective in the activity range we have used it. We have seen no significant toxicity. But if we go to higher activities or more frequent cycles, then the cost becomes really immense, in the range of 40,000 to 60,000 euro per treatment. And therefore, actinium-225 must be considered the first choice isotope for alpha treatment. And the group in Heidelberg was really leading the way with this publication, showing that there is, even after failure of lutetium, a very good response in many of these patients, reaching in some patients again complete remission. However, severe xerostomia became the dose-limiting toxicity if treatment activity exceeds 100 kilobecquerel per kilogram, which is around 10 megabecquerel total activity. And for advanced stage patients, a treatment of about 8 to 10 megabecquerel every 8 weeks seems to be a reasonable trade-off between toxicity and biochemical response. We have looked into this issue of salivary gland toxicity using, for example, Botox to prevent PSMA accumulation. We have meanwhile used more than 6 different agents which were locally injected and some given as a patch and so on. We have not found the best agent up to now, but I'm optimistic that within the next months we will really solve this problem or reduce the uptake significantly. We have now treated actually 6 patients, and I would like to present the data from 3 patients here. All were end stage, all had high Gleason scores, and 2 of them were treated by tandem PRLT, so using lutetium and actinium the same day in the patient. We have seen no significant hematological toxicity, and also what is interesting, up to now we have not seen any significant xerostomia in this patient. Though the take-home messages are that PRLT using lutetium PSMA is effective in end-stage disease. We have seen regression of extensive tumor burden and even have achieved complete remission in some patients as last-line therapy. What for me is also very important as a clinician is that we see significant improvement of symptoms and Karnofsky performance score, and we have definitely a prolongation of progression-free survival as we have already published. And I think we very likely will provide a substantial survival benefit for patients after exhausting all conventional therapies. This therapy is excellently tolerated in nearly all patients. We have seen no or just minimal hematological toxicity, especially in chemotherapy-naive patients. We have seen absolutely no nephrotoxicity, and we have seen persistent salivary gland toxicity in less than 3% of the patients. What is really important is that we can follow our concept of theranostics, which dates now 77 years if you look back to radioiodine. And there are a lot of interesting future perspectives, namely combination with other treatments, new diagnostic probes, especially F18 labeled PSMA tracer, and new therapeutic radionuclides. And prospective trials are urgently needed, and they have already started in Australia, as reported yesterday by our chairman of the session, the therapy study, which one really have to congratulate the Australians to being able to initiate such a very, very important prospective trial in 10 sites around Australia. So I would like to finish by inviting you all to the 5th Theranostics World Congress, which will take place March 1 to 3 in the wonderful island of Jeju in South Korea. Thank you very much for your attention.
Thank you, Richard, for that wonderful talk. I want to thank all of you who attended, also all the speakers who stayed on time, and also my co-chair, Dr. Hoffman. Do you want to mention anything?
No, thank the speakers, and perhaps we can take one burning question from the audience if there are any. No, I'm sure the speakers will be happy to answer any questions after the session.